So suicide screening, assessment, and prevention. You know, there's a lot of stuff that is still pretty, I guess, instrumental in how we assess and screen when we're working with clients who might be struggling with suicidal ideation. Yet, there were some things that even I learned. So for instance, like I have a client who, she really truly has chronic suicidal ideation. She's in her mid-30s. This is something she's been dealing with for a long time. And I often feel like not very effective with her because these are things that just, it's like, think of like the volume knob on a radio. It's always at a 3, the suicidal ideation. Sometimes it gets cranked up to an 8. But through some of the research I did to prepare for this, I'm learning more about some, like, I guess, they're not newer approaches, but newer best practices, especially in working with clients with chronic suicidal ideation. So we'll just touch briefly on that at the end. Because some of you may have clients who, this isn't an isolated thing, it could be an ongoing concern. Oh, my friend Lag is back again. Okay, so we'll see how much we get through, right? It's a lot. However, like you all have the information in front of you, so whatever we don't get through, you know, look at, ask questions, email me. We can set up a time to chat more about it. But I really just want to get through some of the big aspects of what does this look like for us as therapists. Okay, so just kind of briefly some suicide statistics. You know, little outdated at this point, but you know, data tends to be a little lagged, so it takes a little while to catch up. But in 2022, over 49,000 people died by suicide, so that's 1 death every 11 minutes. Many adults think about suicide or attempt suicide, and you can see the numbers. It's pretty staggering. So rates based on year, you can see, oh, my eyes are terrible. Where are we? So 2022 looks to be pretty similar to like 2018. Looks like there was a bit of a dip when COVID started, then a really significant increase in those numbers. I think I'm like diverting for a minute, but it's relevant. Within the LGBTQ plus community, I think there's a real worry that rates of suicide are going to go up because of what's going on politically in our country right now. So I added in some additional resources too. I just want to put this out there in case folks don't know. Like we all know the 988 number for, it's a suicide hotline. There's now one that the Trevor Project created for trans individuals. So it's a suicide hotline for trans individuals through the Trevor Project. And I can send that out. It just, like they just created it in response to the election. Okay, so I realize this is hard to see, but age range and risk level, right? So you can see, and this is something that I know I learned about in grad school when I was taking, I think, like a lifespan class. You know, we've got an age range that's just at greater risk for completing suicide. So you can see the numbers there. And it looks like, yeah, so 2022. People ages 85 and older had the highest rates of suicide. What does this sound like in that age group? How do we know or start to have a sense of, wow, they may really be thinking about this. This may be a real concern because it might sound a little different than the way it comes out of a 14-year-old. So what are people hearing that might work with this age group? Go ahead, Carol.
Worries about burdening their families.
Yes, absolutely. Anybody else?
And definite desire for assisted suicide.
Right.
I'm hearing it more and more.
Mm-hmm.
Honestly,
I know. Yeah.
I just listen. I don't.
Right.
For whatever you got.
Yeah. Amy?
I was going to say loneliness,
Mm-hmm.
isolation, and what I hear a lot is all my peers, my friends are gone.
Right.
And I'm left.
I'm the only one left. Right. I feel like I've lived my life. Right? There's not much more to live for. Sometimes this comes up for folks when they're receiving a medical diagnosis that isn't really hopeful, right? The outcome is pretty likely that of a shortened lifespan, right? So why would I put myself through that, right?
Medicare is insane.
In what way, Linda?
How Medicare is administered chooses what.
Oh.
I have contact with healthcare insurance brokers.
Oh, right.
They talk about how they have to work with the elderly because it's a horrible, horrible system for people who don't have someone to help them.
Right.
Be independent.
Right.
They just give up.
Sure. I have a client right now, she's 65. She is dealing with a variety of health issues. She had a hip replaced a few years ago. She needs the other hip replaced. She had open heart surgery years ago. Her husband died 2 years ago. Then her mother died 6 months later. So just the onslaught, right? So she's just been in such pain and can't get outside, can't go walk her dog because her hip is just killing her. So she finally gets to the orthopedic doctor who says, oh, I don't do surgery. You got to come back in a month. Right? She comes to me, she's going, Sam, I don't want to live anymore. Like, I'm done. I'm tired of fighting, advocating. Nobody's listening to me, right? Prior to this is a woman who had never thought about killing herself, ever, right? But because of the onslaught of just one major thing after another, she got to the point where she said, I don't even want to get to the point of dealing with surgery. She finally goes back a month later to the surgeon who says, your BMI is too high. You need to lose weight before I would even operate on you. So now she's, right? She was like, okay, fine, I'll wait a month, I'll go back. She kind of had a little second wind in her, and now we can't put you under anesthesia because it's too much of a risk because of your weight, right? So talk about just getting slammed down. How do you help a person find the light, right? When you think maybe it would be good for them to have the surgery, quality of life could improve, but they can't hear it, right? And some of us may have experienced things like this too, so it's always a tricky situation. We know this, where some of these things might be going on in our lives or our family member or loved ones' lives, and it's showing up in session. It's like, how do you not over-relate to them? It's hard. Okay, so race and ethnicity. This is really important to point out for a variety of reasons, but often minority individuals and marginalized populations are left out of data, and that's just not okay, right? It's just not. It's never going to be okay. So even when I was looking up stats, when you're looking at suicide rates based on gender, it's still male-female. So it's not accounting for non-binary individuals, et cetera. So my hope is that moving forward, it could be a little bit more inclusive. But look, non-Hispanic American Indian Alaska Native individuals are at the highest rate of suicide. I remember learning about this in grad school. Maybe some of you did too. Do we know why? Why is that population at such risk? Go ahead, Keisha.
Like a sense of hopelessness.
Yeah.
You don't have something really to call your own and do. It's kind of taken from you, and then there's a lot of poverty and things. So.
Right.
Epigenetic trauma.
Right.
Because you were forced, your land was stolen from you. You were forced off the land. You were forced to live places that you did not want to live. And a part of the population, you were murdered because your ancestors were given blankets that were already diseased with smallpox.
Yeah.
There's so many.
Right. Generational trauma. Most of us have heard that term before. Right. And it doesn't end just because our country is a bit more industrialized these days. It's a population of people that in so many ways is really disconnected from a lot of other components of our society as a protective factor, right? Like all the things that Linda was just saying. Okay, so there we go. And you can see here rates for biological males and females. I think we know that females are more likely to attempt, males are more likely to complete suicide. 41% of LGBTQ young people seriously considered attempting suicide in the past year, and young people who are transgender, non-binary, and/or people of color reported higher rates than their peers. This is a population that's more likely to experience chronic suicidal ideation, maybe less attempts, but more chronic suicidal ideation, right? And we'll talk a little bit about, so what does that mean for us as providers? That means regular and frequent assessment. We're regularly checking in with folks about how are we doing? And not in a sense of just like in the world, but like with these thoughts and with these feelings, okay? Probably checking in more than we think we need to, but we got to.
Sam, and I think
Yeah.
there's just a reality, which is, I think that great, those great people.
They are. They absolutely are. And I was talking to Graham about a client that I have who's a trans individual who is 18. Their best friend, who's also trans, completed suicide 2 months ago. And they're starting to believe that they did this because of what they anticipated changing in our country. And they became very hopeless because they didn't. Parents have no idea. My client and other friends have no idea why this person did this. It just really felt out of the blue. And so they're starting to wonder if there was some connection there that they just didn't let anybody know about. So what's the difference between a suicide screening and a suicide assessment? You can, interchange suicide with OCD or anxiety. There's a difference between a screener and an assessment. Does anybody have like a good idea of what the difference is? Screening and assessment? Go ahead, Rachel.
Well, in education, the screening is kind of just like a surface level, where assessment is deeper.
Right.
So you're looking for a flag at the screening level.
Yes.
And then you have the flag and you do the assessment.
Exactly. Perfect. It's absolutely the same thing. And again, it can be applied with any situation or diagnosis. I often will administer autism screeners. I'm not diagnosing autism with anyone, but I'll give a screener just as it gives us a sense of, is there a thing that maybe somebody else needs to look at a little bit more closely? When it comes to suicide, we're the ones that will be looking at it more closely should, a flag come up on a screener. We're not really passing off to anybody else in the work that we do. Okay, so it's a lot of info, right? Screening, again, Rachel hit the nail on the head. Sometimes screeners are built into intakes, right? We kind of have some of that built into ours. I've worked with EHRs where if you indicated yes because someone's having these thoughts, like how it does for us, then you have to kind of provide more info. I've worked with EHRs where it basically shuts, like you're frozen in time and it basically forces you to do a screener or an assessment. Like you cannot move forward until you do a full screening, which I could appreciate that, right? Sometimes I don't remember all of the things to ask. Yeah, so again, we're just going to take Rachel's definition for the sake of time because she did a beautiful job anyway. So best practices in suicide screening. This is not a place where I'm going to go, that's wrong. That, Guy Friday's gone now. He's not going to be critical. It's just regular me. What are some things that people are doing, even if it's informal, to screen for suicide? What are some things people are asking? Are there, tangible things you're referencing whenever something like this might pop up, other than what's in our intake? Anybody? Go ahead, Carol.
Paying attention to what they say about their future plans.
Yes. So what might, catch your attention?
If they don't have future plans.
Yeah.
Or if they speak very calmly about something that should be upsetting to them.
Right. Right.
Like that they were upset about, but now they're calm about. Anxiety.
Okay. So paying attention to how and what people are saying and some of their responses to it. Sean.
So kind of maybe add another angle to that, I just recently did a training that was talking about this, and they said that future plans actually are not the protective factor you could think they were, because they said that a lot of times they'll have I'll have a future plan in case I don't, but I might still do it.
Yes. So that's where there's some changes, right? Because that's always been, a little check, do they have, I think it's on ours, honestly. Do they have hope for the future? I'm going to mess up the language, but I think it's in our Valent screening. So, yeah, go ahead, Bob.
I think you can't shy away from
Bless you.
the question.
Right.
Sometimes the client might deny suicidal ideation, but you can feel something going
Yes.
on. I think as a clinician, you've got to kind of trust that vibe and pursue a line of questioning about it. Give the
Right.
person permission to talk about it. It's not a forbidden topic.
Right.
I'm comfortable with, our having a dialogue about
And I don't know about all of you, but when I was like a new therapist, I remember the first time I had a client come in who was actively suicidal, and I mean, this was 13, 14, I was terrified. I remember going, hold on, I have to get my supervisor, and I like ran down the hall, and I'm like, I know what I'm supposed to do, but like I don't know what to do. It's like it all went out my head. So I don't know about for you, Bob, but I know for me, it's never like wildly comfortable for me to get into that with clients, but I do it because I have to. So I think one of the unfortunate realities is one of the ways to become more comfortable asking these questions is to either practice or be in situations where you have to ask them, right? Go ahead, Carla.
I would wholeheartedly agree. The ACT Act, that training that we took here 10 years ago, more than 10. The most important part of the training was we had to get up and do role playing and ask and ask and ask.
Right.
So asking everyone all the time in different ways, I think is important. One thing I've been asking more than before because I looked at some research is, does anyone in your life ever suicide? Has anyone in your life ever attempted suicide? Because it becomes more realistic in my locus of understanding. Sort of like sadly, if I use social media, things that I never considered, bad things, horrible things, are on this,
Right.
are now they're in my locus of understanding.
Right.
It's not good for me to have that in my locus of understanding.
Right.
So then we have to debrief that. So if the patient says, yes, this person that I knew did that, we debrief. Well, what do you think about it? That was a good choice. Let's really dig
Sure.
underneath what their values are around suicide.
Yeah, I agree. So some of us are using,
Can I ask
yeah.
a question?
Oh.
So let's pretend the answer is yes for passive ideation.
Yeah.
I did pass it.
Okay.
But there could be an argument made for not taking past it. So if they say, yeah, I thought about it, but, I never would because I don't believe that it's good or it's wrong. I keep digging. Do you think there's anything antithetical to that?
I don't,
Like you,
yeah.
I'm a little scared.
So I'll open it up more broadly. It's not necessarily about what I think in terms of like what's my opinion on that. It's more of if I can zoom out for a minute, what would I want me as a therapist to do for that client in that situation? And it can be risky to take things at face value and kind of leave it at the door. Okay, I've known them for a long time. This is a thing that pops up every once in a while. It's probably just because da-da-da-da-da-da-da. That's dangerous, right? If we start to just assume, we're already in troubled waters, right? So I'm taking a page out of Bob's playbook where we've just got to ask, right? Some people feel a sense of relief that we caught it and we're asking, and it's like, I can let this out, right? I don't have to shine it up just because I'm worried what my therapist is going to think. So I do agree on a professional sense of digging. I think of it just more as assessing, right? So even if we have a long-standing, really solid relationship with a client, it's really risky to assume anything. So knowing what kinds of questions to ask, and we'll talk a little bit more about that, and kind of what to do based off of this response that they give is really important. Go ahead, Carol.
Another thing that I like to ask as a follow-up is, okay, so we've made our safety plan list, or these are the things that we've talked about in terms of like how to tend to yourself during this time. Is there anything that is no longer working? Do we need to reassess this? What have you tried that has been helpful? Do you feel like we need to reload it again? And sometimes they're like, yeah, well, whatever, blah, blah, blah. And then sometimes they're like, yeah, well, I tried to do this, and it just agreed.
Right.
Okay, so then we need to find something else, or find some other way to make a connection.
Yes.
Or something.
Yeah. I mean, the people they may have listed as, people to reach out to may not be available anymore. So again, there's nothing wrong with assessing and reassessing, even when there's not ideation or planning or intent going on. Just like, hey, we're updating your treatment plan. Let's take a look at this piece too. just because, we're talking about these things, right? Okay. So I realize this is kind of small, but again, you guys have it with you. So this is where, at least for me, some things really changed. Learning about things I'd never heard about before in terms of screening and assessment. The Ask Suicide Screening questions, which is through the National Institute of Mental Health, is a valid measure that's highly recommended. It's a 4-item suicide screening tool designed to be used for people ages 10 to 24 in emergency departments, inpatient units, and primary care facilities. I looked at it, I think it's absolutely applicable in our environment, and I like that it's short, right? And these are probably even questions that if you look at them enough, you can just memorize them. You don't even have to pull up the instrument. The Suicide Cognition Scale, this is interesting. Ask questions that get at emotions that can render people vulnerable, such as feeling that people would be better off without you, or that no one can help you solve your problems. So what I was reading, just in terms of literature, is that some of the screeners or assessments we've been using aren't asking the right questions, or they ask them in a general way, but they need to be more specific, okay? Because there's too many air pockets for people to go, well, no, that's not really it, but it kind of is, so they might say no, because that question doesn't accurately capture what they're feeling. It only captures a part, so they're not gonna get flagged when really maybe there is some substantial stuff going on for them. So that scale is also a valid measure. So using the Suicide Cognition Scale and the PHQ-9 together, according to research, is a really good combo. It's a good package deal. Go ahead, Sean.
Do you have access to any of these in Baylor?
You can get them all PDF online. Yeah, and so I'm happy to add those to the shared drive that we use, but I can also just email them. These are the types of things that I either save as a favorite on my computer so that I can get them quickly, because when I get, this is shocking, I know, when I get stressed, I can't think clearly. Like, I know it's really shocking because I'm so composed all the time. So I just want to be able to grab something without having to dig around through a bunch of folders. Go ahead, Susan.
Yeah, the patient health questionnaire is the same thing as the PHQ-9.
Right, it's there, yeah.
The other ones are, yeah, not.
Okay.
That's the next page.
Come on, friend. Yep. So the Columbia, people will just call it the Columbia Suicide Severity Rating Scale, 5 questions with 2 subsections assessing intention and behavior. The ASK, the Suicide Screening Questions Brief Suicide Safety Assessment, blah, 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 blah. 5-step assessment process to be used with adult clients in an outpatient mental health setting. So there's several. I wanted people to have options in terms of the ability to take a minute and just go online and look at each of these, or look at them on the shared drive to see which feels usable for you. Go ahead, Carol.
So what's the cutoff for adults? Is it 18 plus?
I believe so, yeah. I am not going to do great with a multi-page, several dozen question screener. I'm not. 4 or 5 questions for me is right where it needs to be, especially in situations like this. So a lot of these are pretty brief. Some aren't. Okay, so best practices in prevention. So some of the things we listed were screeners. Some of those were more assessments. So again, make sure to just take a peek so you know which one to use in different situations. So when we think about prevention, again, this is where some things have changed, at least from the time I took my crisis class in grad school until now. Generally things are still the same, but there are some nuances. We always want to be using evidence-based tools. So, this seems kind of silly, but that's why when we talk about these things, and Sean brought up, we need to have access to them, because anybody could do a Google search for a suicide screener and 1,000 things are going to pop up. How do we know if they're valid or not, right? It could look legit, and maybe it is, but I don't want to be using something that's not, designed for the demographic my client, falls into. Make sure you're using an evidence-based assessment for suicide risk as well as evidence-based safety planning protocol. The Brown-Stanley safety plan is amazing, and that's also one that I have just saved on my laptop. I can send out this PowerPoint too, because I think there's a couple hyperlinks in it that you can just click on and it'll take you right to the safety plan. We're actually going to talk a little bit just briefly about safety plans and how some people feel like they don't work, right? Has anybody else been in the mindset of like they just don't really do anything? Yeah. I mean, there isn't much research that shows that they are wildly helpful in terms of preventing suicide. This is going to sound the way it's going to sound, but sometimes it's a check the box type of situation, like helping a person be able to identify these things, talking about them, at least verbally acknowledging what those supports may look like. I don't know that the formal, document is all that helpful. Sometimes talking through and having people realize, oh, there are people. I do have more people than I realize can be helpful. Go ahead, Sean.
Good argument I heard from them recently that it helps bring to mind these things that you may know if you think about it in a private moment, you're not thinking about it.
Exactly.
You have it somewhere at hand to remind you of what
Right. But show of hands, how many people have had clients who are suicidal that are like, good thing I had my safety plan? Carol, put your hand down. Okay, yeah. Carol, it's not, we're not all raising our hands, are we? But I'm pretty sure most of us have had clients in this category. Go ahead, Bob.
I would separate the clinical issues from the litigatory.
Yes, please.
Having sat in several depositions as an administrator with attorneys where we have had client suicide, they're going to take you through your suicide policies and procedures.
Right.
They're going to look at the documentation
Mm-hmm.
in the file.
Mm-hmm.
If you're saying that the client is suicidal, you've really got to have clear documentation
Right.
that you have responded to that
Right.
in a clinical fashion.
Right.
Then you have to know about when you decide to commit somebody.
Mm-hmm.
They're a danger to themselves.
Right.
What are the criteria for that?
Right.
And it's also important to be able to, in an organization like this, talk to the clinical director if you have a question
Right.
about the client that you're seeing,
Right.
and then show some documentation about that consultation,
Absolutely.
just from a legal standpoint.
No, you're exactly right. And, especially for people in private practice, and again, that doesn't pertain to us, when insurance companies do audits and see, oh, wow, this, you're noting on this date that this client kind of was flagged on a suicide screener. They will contact that provider and go, you need to show me all your supporting documentation that tells me what you did because this client was flagged on a screener. Again, solo practitioners tend to be, I don't want to say more at risk, but we're a bit more protected in an organization like this. So some of these things I might mention, it would be more on the rare side that anything like this would happen to us, but it does, these things happen, like what Bob said, and not only just in the court of law, but a suicidal client. If you're documenting these things, you're right. And it's not just a cover your butt situation. It's really because we need to be showing that we're taking this seriously and not just, they just do this every couple of months.
If I have a depressed client, I really spend a lot of time with the protective factors. I think that's great within the documentation
Right.
tool.
Right.
Let's go over these protective factors and each one of them and talk about what they mean.
Right.
And I find that part of it very, that part of the tool very helpful.
Yeah, I agree. Because it could look very different today versus 3 months ago, or when they did their intake with you however long ago, right? So this is really important, and I've had this happen, and it was very scary. Create a plan for maintaining contact. Discuss a plan for reestablishing contact if there's a disruption in the telehealth service. I had a client who was actively suicidal and the internet kept cutting out. That is terrifying to me. And she's on the other side of the state. She's near Philly, right? So it's not like she's in Sewickley and I kind of have access to resources here, right? This is a thing. I mean, a lot of us do a lot of telehealth. If you haven't already, there's probably going to be a situation where you're working with a client and this stuff comes up. It's like, what am I gonna do? Like, they're not in my office sitting here, right? So discuss a plan. Really at intake is what the recommendation is. Like, hey, whether we're gonna exclusively be doing telehealth or from time to time, let's figure out what we wanna do should we lose connection, right? Does that mean calling each other? Does that mean trying to rejoin the session? Come up with a plan and document it, right? As soon as I start to have tech issues in a session, I go, okay, like remember what we're gonna do if we lose each other. Because usually if it starts to get glitchy, unfortunately it doesn't tend to get better, at least for me. So that's part of it too, right? Obtain the client's local EMS information. This is like for telehealth, right? We wanna know what's around them. They can help us with that. We can do some Googling around and try to find that information. Document the client's local emergency medical response information and the closest paramedic location. Because if you call, like my client who's in Philly, if I call 911 here, I'm going to get Sewickley, right? So I need to know who to call out in the county that she lives in, right? Questions about this? I'm just trying to move us along because we don't have a lot of time. Go ahead, Matt.
So something I learned in one of my recent classes, especially with telehealth,
Yeah.
cross streets. You call 911,
Yeah.
you give them
Oh.
an address,
Yeah.
they can transfer you to that 911 dispatch.
Yeah.
So if they're like, someone's in their car doing teletherapy,
Right.
get a cross street. Or if you give that to them their home address, they can patch you right over to the local cross.
Okay. Good to know. Thank you. Okay. Okay, so this is a really important addition, I think, to suicide prevention training, really because of the last 4 years. Really prior to 2020, I truly only ever did one Zoom session ever in a 20-year career. This is really a thing. So again, if we haven't experienced it yet, unfortunately, you will probably experience it at some point in the future. Okay, so requesting their location. I mean, I've had clients pop up in telehealth and are pretty much in the same place every time I see them, but occasionally I'm like, where are you? Like, are you in your house? Like, where? No, I'm at da-da-da. I'm like, okay. So just as a best practice measure, just always ask them, like, hey, where are you? Even if it's not a high-risk situation, just ask them where they are so you can document it. Because if they're not at home, if they're at their, like I had a client log on, she's 18, and I'm like, where are you? She's like, I slept over at my friend's house. I was like, oh, okay, can you like turn a light on? It was like pitch black. So it's like, geez Louise. But because when I see her, her room is usually pretty dark, I could have easily thought she was just at home, but she wasn't, right? So just as a best practice measure, ask where they are, put that in your note, making sure we have an emergency contact info prior to the start of the appointment. The client I was mentioning to you all who has some pretty lifelong suicidal ideation was in session. This was a while ago, and similar to some of the stuff Carol noted, her reaction to some pretty serious things was pretty flat. You could just tell she was starting to really disconnect. Based on other things, I was very concerned and said, listen, I really think you need to go to the hospital. She did not want to go. She gave me permission to contact her emergency contact, who then I had them on the phone while I'm virtual with her, and we basically had like a 3-way conversation about how this was gonna go. I stayed on with her until her friend got to the house. I laid eyes on her. They went to the hospital, and friend contacted me later to let me know what was going on. That was a pretty seamless situation. It can get very clunky and very bumpy. This person happened to be available. They weren't working. They could get over there very quickly. That was kind of an ideal response in that situation. Okay, so some of this is redundant. So steps to take after a positive suicide screening. If something's popping up, and again, I like what Bob said in terms of that, I just call it the clinical intuition. You just get these feelings. It's just like, oh, something, right? So that feeling may lead us to do a screening, which may then lead to more of an assessment. For clients who have or experience chronic suicidal ideation, best practice states we really need to be assessing them every session, every single session, right? And that could be one of the 4 or 5 question assessments that we talked about. Obviously, you want to document it as well. Let me go back. Yeah. So again, if someone pops up positive on a suicide screening, you need to move right into an assessment. I want to stop for a second. What kind of experiences have we had where we're concerned, we ask some questions, and we become more concerned? Have we had experiences where clients are pretty willing to engage in this with us, start to shut off and, shut down because they're worried? Like, what are some experiences people have had when you've had to take it a step further to assessment? I've had a wild variety of things. Very guarded, yeah. Mm-hmm. Yeah. Yeah, agreed. Go ahead, Carol.
I've had one client in particular get very frustrated because we were redirecting the flow of the conversation away from what she wanted to talk about.
Right. It's like, why are we stuck on this, right? Yeah. People get scared, right? They think I'm going to have them committed immediately. Yeah. What are we doing? Suicide assessment and high-risk clients. Some of this we've already talked about. Assess for access to means, right? This can be a little trickier when it comes to like telehealth. Again, not that it's all that markedly different when we have somebody in our office because they're not at their home. My experience has been people tend to be a bit more guarded when I'm asking these questions over telehealth than in my office. I don't know why, like more reluctant to, because I might say, well, can you show me, right? Or can you walk me over to that and we can have it locked up? There can be a bit of like, no, like I don't want to do that. Again, safety plan template, Brown Stanley, safety plan is great. Identify individuals in client's current environment who can provide care, supervision or check-in on client. For the young man who came in to Samaritan last week, he is an active client at Staunton Clinic, actually, and so I was like, called them with his permission, got his prescriber on the phone, which let me just tell you that you can never get anybody on the phone. And then I also got in touch with his mom, who lives down the road, so she came, and it was like a 4 or 5 person effort to help him through that situation. And it only went that well because people were available and accessible. Because it would have been interesting if mom wasn't home, she had just gotten back from a trip, or I couldn't get anybody on the phone from Staunton. So those were the people in his life that could be supportive. And mom ended up talking him into going to the ER to be evaluated. Go ahead, Carol.
One thing that has happened for me a lot with my clients who have SI is that these feelings scare them.
Mm-hmm.
And so they tend to be very upfront with me. I mean, I'm sure this doesn't always happen, but the ones that I've experienced have been very upfront with me about I've had my boyfriend take all my sister
Right.
away. I told my mom to lock the medicine.
Mm-hmm.
We went through my room, got rid of blah, blah, blah.
Right.
And so, I've experienced them being very
Good. Good. No, and I mean, like my client who I've mentioned a few times, she's an adult, she lives at home. Her mom administers her meds every day. When she got out of inpatient this last time, that was a part of her being discharged, is an agreement that mom, and she's been out of the hospital for a while now, but her mom still doses out her medication. It's just better that way. Because this last attempt, she overdosed on one of her medications, right? So if a risk becomes imminent, stay on the phone or computer with client while attempting to contact their emergency contact, right? It's like, what's my next move? Do I need to get 911 there now? Is this more of we can call their contact person? It's like a multi-step thing. If this isn't going to work, what am I ready to do next? There's a lot of that happens, and I find that for me, I have to dial in my focus in a really intentional way. I have to just hit these marks, okay, let's go to emergency contact. Like my client who ended up at the hospital that one day, I didn't feel like I needed to call 911. based off of what was going on, I felt like her friend would be really supportive and probably able to talk her into going to the hospital, which is ultimately what happened. Calling 911 and having the police come to your home or the office to transport a client to the hospital can be extremely traumatizing if anybody has heard these stories retold or has even witnessed this happening. That's not across the board, but we also know that paramedics and police aren't always trained in how to de-escalate or respond in crisis situations, so it can take a really hard situation and just crank it through the roof for people. Yeah.
The young lady, not a few months ago, last week was Nancy, she called for help.
Oh.
And law enforcement showed up, and she's dead.
Yeah.
And they knew that she had a mental health diagnosis. They knew this. There
Yeah.
are communities where you can, you have to be very careful
Right.
when it comes to contacting 911.
Right. I've worked a lot of my career with people who have autism, so kids and adults, and there have been several times, especially when I was doing community-based mental health, where the police came and this is Allegheny County, I don't know if it's the same in other counties, but what we were able to do was either client or parent of client would contact the local police department, and basically they could, in their system, whenever that family called for support, it would get flagged, like, listen, this individual has autism, they're nonverbal or whatever, just as like a heads up, because oftentimes people in crisis might be viewed as being on drugs or being under the influence of something when that's not it, and be treated in that way, right? So that's a thought just in terms of safety planning, especially for our folks who have more serious and persistent mental illness, like the young man who came in last week. He would probably be a guy that I would encourage him to let the police department know, or mom let them know that, like, if he pops up, right, if we're calling, this is kind of the approach we need to take with him, right? Because I guess there was something that happened a while ago, and the police came and he reached for the officer's gun. So even I know that's not very good, right? Okay, we've got just a few minutes left. I just want to try to get through a couple of things that we haven't yet, so apologies for skipping through. We've talked about assessing suicidality at every session, asking about it. Are you asking the right questions? I thought this was really interesting. So for example, the rate of suicide for Black adolescents has increased in recent years. Instead of harming themselves outright, they may put themselves in harm's way because they're willing to die, right? So they may engage in more aggressive kinds of behaviors that draw harm or fire. So how do we ask about that? Because this isn't necessarily like, are the meds locked up? Are the knives locked up? Do you have access to guns? How can we ask about this? Any thoughts? If anybody just wants to talk, I have to get more water. What do we think? Yeah. Mm-hmm. Oh, I walked past it. Yeah. Yeah. Mm-hmm.
Sometimes just talking or listening to social interactions, who they hang out with, what they're doing.
Mm-hmm.
That
Right.
kind of gives you a little more information too. Because if you know that they're hanging out with certain people that are doing certain things,
Yeah.
that gives you a little more information of where they are.
Mm-hmm. Yeah.
The language they use, like, if they say something like, well, something happened to me, I wasn't there.
Right. Like, if he shot me, he shot me, right? Like, I wouldn't get out of the way. Yeah. And I think in the same way that you can ask directly, like, you know, well, you're telling me that you're thinking about killing yourself. How would you do that? Don't lead with, would it be a gun? Would it be pills? Just, how would you do that? What would that look like? Right? I might go, I don't know. If something pops up, I'm just going to do it. What does that mean? What's the image in your head when you say that to me? Right? Because there's probably a picture in there of how they might be anticipating that. So this is good to know. Are we asking the right questions? We're not asking in a way that is passive, right? We're not asking in a way that it implies no is the answer. Do you want to die? Are you thinking about killing yourself? It's got to just be blunt, right? therapist Sam 20 years ago would have been like, well, are you like really worried like about your life? That's how it would have come out. Terrible. Now I'm just like, we just go for it. Go ahead, Carla.
So my follow-up to that first very blunt set of questions, to you, asked
Yeah.
very blunt. Then I say, okay, well, I'm going to dive into that. So have you ever thought just if you died, it would be better for yourself or someone else?
Sure.
And then that's the jumping off point for that next question that I will say I started a little bit because it's harder to say
Yeah.
being suggestive, but for instance, I don't say this to them, but how many people have told me they just want to drive off the edge of the
Right.
highway? How many people have said, I'll put myself between me and the train? I've had many people say that. I said, so if you said yes, then maybe you really just think it would be better if you died, that's when I go to that, well, how would that happen?
Right.
How could that happen?
Right.
And some people bite and some people don't.
You're right. Right.
But I get really interested in that. And then I do a lot of, well, this is the sort of thing I would ask anyone. I've asked this of my cousin. I'm going to ask you.
Sure. Yeah, I agree. It's like,
I actually have asked it of my cousin.
well, I'm sure you're not the only one.
And that's important.
I agree. We've only got about, yeah, who said? Yeah, yeah.
Because what you just talked about, it just reminds me of like suicide by cop.
Oh, right. Yeah, exactly. Right.
So, I guess this goes to like a commitment.
Yeah.
You really suspect something. And this may be also somewhat of a Bob Fisher question. Just
Oh.
Because you kind of have, if somebody is saying, kind of like, I wouldn't mind dying in a situation where, police officer just shoots me. What does that look like when you're calling 911 for a commitment?
Yeah. I think that's where we advocate on behalf of our client. Looking,
The client may be kind of going, well, that's not going to happen.
Right. Right.
I think I'm talking about such a rare situation you may face, but I'm just kind of curious about that.
Yeah.
If you're calling 911 for committal, you're trying to do that.
So in a situation like this, which again, I'm not going to say it's not common, I just don't have any data because it may be more common than we realize. It's how can I, as the provider who's attempting to have this person involuntarily admitted, how can I get in direct contact with whoever's about to have direct contact with my client? So if that's, how do I get in touch with the police officers responding, which can, dispatch can patch you through to the police officers. There was one time in my career where just a really horrendous situation where I actually ended up having to do that. The SWAT team was called for one of my severely autistic clients, and it was a whole disaster. And I had to be like, wait, this is not what you think it is. So trying to weed out people and get to the person who's going to have contact with my client. But it's really a systems issue, right? Police aren't trained in the way that they need to be trained. They're responding in the way that they know how to respond. So there's going to be a gap between me and the response, regardless of how hard I try. It's a real risk. It is. So can we divert, right? Is there a way to get them to the hospital without police involvement? Would be, I think, the preferred method, right? Okay. I just want to finish up real quick because I don't want to hold people over. Collaborating with parents and caregivers. For those of us that work with kids and adolescents, we've got to be really mindful of how we are using the adults in that kid's life to collaborate when there's a high-risk situation like this. Although letting a client's parent know that they're thinking about hurting themselves is not a breach, it can feel like a breach to the client. So this is what I tell everybody in my intake speech, that should something like this come up, I want to talk to you, my client, about it first, and then we plan accordingly. I try really hard not to do anything that feels like I'm going behind your back, but there are situations where I can't get to you and I have to do something, right? This can feel like total betrayal to clients, especially kids. So just be mindful of okay, am I talking to my client first? Am I reminding them that hey, we talked about this before and this is what I'm going to have to do, and you can be mad at me, I can handle it, but this is what we got to do, right? Okay. This is a good slide to just peek at as you all move forward, working with clients that kind of fall into this category. Brief CBT, the CAMS assessment I've used once. It's pretty hefty. It's not a one-pager. It's multiple documents that you use in every session, but it's really helpful with clients who have chronic suicidal ideation. Any of these are to be used over a brief period of time, but these aren't things that, like, in a crisis, you're going to be whipping out the CAMs. These are to be used kind of consistently over a short period of time. So look into these if you haven't already or don't know about these. I just gave more of a description. I think where I want to stop is just how are we taking care of ourselves as therapists when these things come up in session? How are we processing? How are we debriefing? Are we shoving it down and moving on to our next client? Maybe we can just take a minute or two and some people can share what they do to take care of themselves. What does that look like for people?
Every time it's happened to me, I call my supervisor.
Yes.
I don't hold it in my own heart.
Yeah.
I'm sharing.
Okay. Good, Carla. Good.
It's too much for me.
I'm with Carla on this one, I have to tell somebody.
Yeah. Mm-hmm.
Even if it's not, like, I will tell my supervisor next time I speak to them, unless it's like urgent.
Right.
But in the meantime, you know, I will say, put them in details, of course.
Right.
I'm really worried about this one client, you know, and get comfort from my friends and family.
Yeah.
It's really hard for me, I just need to say something about it.
Mm-hmm.
Just kind of recenter that way.
Right. Anybody
I've
else?
also told the
Yeah.
front office staff.
Yeah.
I told Lucy, I don't know if I've ever told Matt, but I know I've told Lucy in case they call.
Okay. Yeah.
I think it's not just about the suicide cases.
Right.
It's about like when you are triggered.
Oh, yeah.
Sessions, like, you know, what are you doing? Because that is a quality of results as clinicians.
Right. It doesn't have to be the more intense situations when we're checking in with ourselves. It's really got to be a regular part of our work. It's too easy for things to pile up and we get to Friday and feel like, I don't think I want to do this job anymore, right? When some of that could have been maybe sorted through a little sooner. I mean, I am not always available, right? I'm seeing clients too, but I try really hard to make myself available when things come up. So even for folks that I haven't had a lot of contact with, please don't hesitate to reach out. If anything, I can at least be an ear, right? Or a presence if you just need to get some info out there. Go ahead, Susan.
Yeah, the older I get, the more important it is for me to nourish my spiritual self.
Right.
And so I no longer put back-to-back sessions. I'm a part-time therapist.
Mm-hmm.
I need space.
Yeah.
I might go to work, come and fight for 10 minutes. I might do a 30-minute meditation.
Yeah.
I might step outside for 20 minutes.
Mm-hmm.
I just incorporate all of that kind of
Yes.
self-focus in the spiritual sense and a well-being sense. I just integrate it into my day-to-day life.
Yeah. I like.
find it enormously different than my experience, say, 2 years ago.
And think about that in terms of even clients who you know might be higher risk or really struggling. Think about how you want to schedule them, you know, right at the beginning of your day, middle of the day, end of the day, as much as you can control that. But I agree. I've had to cancel some appointments later in the day because it's been so intense for whatever reason, and I just can't do it. It won't be of benefit to that next client, right? Go ahead, Keisha.
Sometimes I will just pray, because there's
Yeah.
really nothing else, like, once you know, do the assessment, but there are times when I'm just like, all right, God, there's
Yeah.
not much else I can do.
Right.
And then also, I know this might sound weird, but there is this game called The Sims, and I will just play
Yes.
the game.
That's not weird at all.
It just helps me relax. Yeah.
I like that for you. Yeah, absolutely. Sims. Well, thank you all. I know we had to kind of scooch through suicide prevention because the game show took over. So please feel free to look through other information. I can send you the HIPAA stuff if you want it. You just have to email me. I appreciate all of you. I appreciate your energy and your participation. The game show will be a yearly thing. I'm just telling everyone right now. So thank you all so much, and I hope you have a good rest of the day.